Hello, how is everybody? I do have to take one moment to apologize to everybody who took time out of their day yesterday. I had a small health alert and ended up having to bump this to today. So for those of you that tuned in today, I am deeply grateful. And thank you to Zomedica for letting me sit here and bore the pants off of you for the next 40 minutes, basically. So if everybody's ready to go, then let's have a wee chat about how chronic injury has a really big impact on our tonic and phasic muscles. So let's have a quick look at our learning outline. So we're going to go over a little bit of, a little bit of review. What are tonic and phasic muscles? Our friend who is woefully overworked and underpaid, fascia. What happens to biomechanics during and after injury? I mean, it makes it sound like, we're working on cars. And basically, as a rehab professional, we are canine and feline car mechanics. So if a good car mechanic knows how a car runs correctly, so when it breaks down, it can, that mechanic can go in and say, yep, you need your wheels aligned. Much as I would like to realign the wheels on most of my canine patients, it is not possible. But knowing and understanding how the body works normally, you get a better understanding of how things happen and how this chronic injury has this knock-on effect, and you get faulty biomechanics. We'll talk a little bit about the role of manual therapy, and then I have a kick-butt case study for you that hopefully will tie everything together for you. So what connects us all? I mean, humans, equines, canines, felines, fish, birds, amoeba, everything, we all move. So movement is obviously, it involves a symphony of physical and chemical interactions between tissues in the body. And everything in the body is connected by nerves, a blood supply, muscle, fascia, bone, tendon, and ligament. So everything is connected. So when considering physical rehab for our pet patients, it's really important to know how whole body movement changes as a result of injury, surgery, and chronic disease. And I say chronic disease because that'll be a little bit, plays into our case study a little bit later. So muscle connects, supports, and moves the body. Interwoven into all of this is the fascia. So together, the health and structure of movement of muscles of the body is maintained. So injury, chronic disease, and surgery all can have an impact on the way the body moves and sustains itself. So physical rehabilitation, including manual therapy, land exercises, underwater treadmill, there's a whole slew of things that we have in our toolkits as veterinary rehabilitation practitioners that we can help the body in correcting maladaptive posture. Now, what do we mean about maladaptive posture? Posture that serves no function whatsoever. So, it's offloading, it's cranial rotation, it's caudal rotation, it's limping, it's stiff gait, decreased joint range of motion. So maladaptive posture to improve health, endurance, and strength and metabolism within the cells and within the muscle itself. So it's really important to understand the accumulative effect of chronic disease on postural change and the adaptations to both tonic and phasic muscles within the body system. So let's take a quick look at our tonic and muscle friends. So muscles can either be tonic, which are responsible for posture. So if you're anything like me, my mum always used to yell at me, sit up straight, you're round-shouldered. Well, my tonic muscles are responsible for posture and help me keep a nice straight back when I'm not absolutely dog-tired. Phasic muscles, which are mainly responsible for movement. So tonic muscles are also referred to as what we call anti-gravity muscles. And I want you to just take a minute to remember that, in your average canine, not your sports canine, not your super buff canine, but 40% of the body comprises of skeletal muscle. So you get this central contractile belly with a tendon at each end, which originates on a bone, inserts on another, spans a bone, and as the muscle contracts, the distance between the origin and the insertion shortens, and the bones move in relation to them. So bones are a scaffold, and muscles make them move. Without our muscles, we would not be able to move at all. So contraction of these muscles depends on types of fibers recruited. So we get these fast twitch or type 2 fibers that are thicker and have rather an extensive sarcoplasmic retinaculum, and that's for a rapid release of these calcium ions. So these fibers fatigue really quickly and they're adapted for movement such as jumping or sprinting. So it's an energy reserve of a fast explosive motion. So you basically, it's a bit like a firework. It kind of gets let off and goes bang, and then all the sparkle and everything's over. So there are two types of type 2 fibers. 2A are oxidative, and they primarily rely on anaerobic and glycolic metabolism. And type 2B just rely on glycolic and anaerobic metabolism. So we're going to take a quick look at what these muscle fibers look like. So on the right here, we've got these fast twitch muscle fibers, which are actually white. So you'll see a lot more proliferation of those white muscle fibers, obviously, as opposed to our slow twitch muscle fibers. So slow twitch, or these type 1 fibers, have a thinner muscle fiber and a larger amount of myoglobulin. So these fibers rely primarily on oxidative metabolism and are adaptive for continual contraction. These are the workhorses of the body and the workhorses of the anti-gravity muscle group. So therefore, they're supposed to fatigue less quickly. So think back to, you see some of these patients that are coming in, especially some that have chronic metabolic diseases, or some that have, chronic long-term cruciate issues. If they're offloading, they'll start to walk, and you'll sometimes hear owners say, oh, he's fine when he's walking. It's just when he stops, he doesn't sit, he just lays down. So what's that actually telling you? These slow twitch type 1 fibers are activating and trying their hardest to kind of work and keep this animal upright. But when the type 2 fibers are done with their motion and moving, everything comes crashing to the floor. And obviously the anti-gravity muscles get, over fatigued. So muscles contain this blend of muscle fibers, and the proportions of each will depend on their use and are adaptive based on training and exercise, which is why rehab is so important. The strength of the contraction can change by varying the number of active motor units or the rate at which the motor unit is activated. So there are high percentages of type 1 fibers in postural muscles, whereas type 2 muscles are primarily used for power and speed. So here we have our slow twitch fibers. So you'll see they're fibers in red. So you'll see there's a lot more of them. So they have that capacity to store more energy and create more work and maintain a lot more tone. So one muscle fiber is innervated by one neuron, and motor neuron acts on branches to innervate multiple muscle fibers containing thousands of myocytes, and it controls the contraction by directing the action potential along the efferent neuron. So a muscle contraction is cumulative contraction of many motor units. So it's a bit like a huge tug of war. The central nervous system can instruct the number of motor units that contract at any one time through recruitment, and the force of a contraction can easily be changed by increasing the frequency of activation of a motor unit. The recruitment of motor units occurs in an orderly manner. We're English, I'm English, we like orderly manner. If queuing was an Olympic sport, I think the Brits would win gold, hand down. So according to the size of the motor unit, so smaller units activate first, with this resulting gradual increase in small precise amounts, and an increase in force will result in larger increases in contractile force, giving a nice smooth contraction. So the central nervous system obviously commands the percentage of motor unit recruited to be active for extensive periods of time, postural anti-gravity muscles. One of my favorite pictures. So next time any of you do surgery, next time you think about a muscle, you feel a muscle, remember this picture. So inside each muscle fiber, we have a fascicle. We've got the muscle fiber cell. you've got myofibrils down to the actin and all the way down to the monofilaments. So this is one small segment of one small muscle. So I want you to just remember that when you've got muscles and you're feeling muscles, you've got all of this activity and all of this amazing physiology going on in front of you. So let's have a quick chat about anti-gravity muscles. And we're not talking about pugs in space, but as the term implies, it obviously means to prevent gravity from overtaking the body and making it collapse. So these muscles activate when the patient is standing still and during certain points during the swing and stance phases of gait patterning. Weakness in core strength and anti-gravity muscles will lead to a weakness during standing. We get altered gait patterns and a maladaptive posture, which is why these anti-gravity muscles are so important. There's a whole list of anti-gravity muscles. We have a set of the shoulder extensors, and it basically will vary when this muscle becomes an anti-gravity muscle at which phase of the swing and stance phase of gait that the dog is going through, or the cat for that matter, whether or not it's an open chain or closed chain muscle action. We've got shoulder abductors and abductors. We've got some of the elbow extensors, and obviously we've got some of the carpi and digit flexors as well. So next time you take a look at a dog, if you're walking, especially if they're in the clinic, take out your phone. Everybody has gait analysis now. It's on your phone. Fire up your video, put on your slow motion video, and just take a couple of minutes just to video that dog walking backwards and forwards. And then just take some time to slow that video down and just watch what's happening between all of the muscle groups as that dog is walking. And then imagine which of those become sort of anti-gravity muscles, phasic and tonic muscles. And I think it'll give you much better appreciation for what an amazing thing that we actually get to deal with. I mean, we're privileged to be able to deal with these patients every day. And I think, you know, it goes something to be said about, you know, just understanding biomechanics and how dogs walk around every day and don't even think about what they're doing with their tonic and phasic muscles, where there's a bunch of us that are going to the gym and working on our tonic and phasic muscles very hard. So just keep that in the back of your mind, that we really are blessed to be able to work with such an amazing group of critters. So some of the hind limb anti-gravity muscles, we've got some of our hip extensors, our hip adductors, our stifle extensors. We get some of our hock extensors and also some of our digit flexors. Trunk and neck. These guys are hard workers. You know, we've got legs on the bottom that obviously support, but they would be nothing without all of the muscles in the neck and the trunk. So we've got a lot of C1 and C2 action. We've got our cervical extension. We've got cervical side bending, cervical rotation, trunk flexion, trunk extension. We get the side bending with the trunk, and obviously trunk rotation as well. So all of these muscles in the trunk are really important to help support all of the other muscles and stop the body from collapsing on itself. So let's take a look at fascia, a little bit more like this pug who desperately needs a nail trim. I mean, have you ever seen such hideous nails? Oi. Anyway, so overworked, underpaid and overlooked is fascia. I mean, fascia is an amazing organ, and I think, you know, we can do a lot with our manual therapy to make our little fascia look a lot better. So the body's not just connected by muscle, but obviously by fascia as well, and it's a flat interconnective web of tissue throughout the body. You get adhesions in the fascia that are a result of injury, surgery, or damage, leading to a maladaptive posture, gait changes, decreased range of motion, reduced muscle strength, and discomfort. I can tell you that being in the veterinary field as we all are, I can tell you that if you take your thumb and forefinger, put it just at the base of your neck, right where your shoulder starts, and pinch, I can tell you that that is the discomfort from a trigger point, and your fascia underneath and your muscles are just screaming. So I really do advise you to go get a nice body massage. So fascia is able to transmit approximately 40% of the force of a muscle contraction, which is pretty amazing. It also helps separate muscles, allowing them to perform efficiently and move in different directions, and stops them from clogging together. So deep fascia can either be episymal, so we got this connective tissue sheath surrounding skeletal muscle, or aponeurotic, which is obviously a deep fascial sheath. So let's have a look at biomechanics and injury. I just have to say, I don't have anything against pugs. They just take the damn cutest pictures. So obviously injury occurs when there's sudden stress that overrides the body's ability to overcome it. Duh. So chronic long-term stresses on an area can cause a lot of long-term adaptive changes when the body is unable to keep up with repair and recovery. So after injury or surgery, the body adapts around it. Gait changes, posture changes, and as an altered motion continues, the muscles adapt to produce this minimal system stress, leading to these secondary sites of stress and injury. So disuse can occur, causing a decrease in muscle fiber size and number. So we're talking about atrophy here. So type 1 muscles are obviously more affected, leading to a decrease in strength, abnormal posture, movement, joint stress, and muscle fatigue. We get all that just when injury occurs. So thinking about injury, what slip and falls, what do we get? Torn cruciates, partial cruciates, cruciate strains, cruciates that aren't fully cruciates. I mean, imagine a dog that is like maybe a 2 out of 4, like a 2 out of 4 lane, limping just a little bit, foot's on the floor, but they're not fully extending that stifle. What's happening to the muscles of the hind leg? They start to atrophy because they're not getting that proprioceptive input. So we get this disuse and a decrease in muscle size and muscle type. So we get muscle atrophy and muscle weakness. I chose a Frenchie here instead of a pug. So whereas normal muscle is usually soft and pliable upon palpation, muscle dysfunction will cause said muscle to contract without the ability to return to its previously soft, pliable state, and remains in that fixed, shortened position. So this leads to a reduction in circulatory flow, lymphatic drainage, and a reduction in range of motion. Left untreated, over time, muscle integrity changes, leading to increased tone, resistance to palpation, and decrease in joint range of motion and movement. So imagine our little French friend here jumping through the fields. What if he got stuck in this position? What if he overstretched his hamstrings, his glutes, his quads, his shoulder stabilizers? He's basically built like a little potato. He's not built for sudden bouts of speed, and the chances are he's going to overstretch a muscle, which is going to prevent it from returning to a nice, pliable, soft state. So we're going to see, say we take this picture, for example, a reduce in hip flexion, elbow extension, elbow flexion, shoulder flexion, probably some compensatory tension within the cervical muscles and also the lower back. So next time you see a case in your practice that has elbow arthritis, stifle arthritis, hip dysplasia, IVDD, spondylosis, then just think about what's happening to the muscles around that area and also on the other side of the body. How is the body compensating to kind of allow that area to try and relax? This is a rather unfortunate picture, and I really hope this would be none of your patients having a rather slip and ungraceful dive into the water. So the anti-gravity muscles mentioned earlier are key to maintaining normal posture, which in turn relies on muscle integrity. So during injury, the body will activate its coping mechanisms of compensation as the muscle integrity changes and progresses. The postural changes due to injury, disease, or surgery can lead to this development of these myofascial trigger points. So these are basically defined as these hyper-irritable, kind of angry little loci within a taut band of muscle located within the muscular tissue and associated with the fascia. They can be painful and directly affect the autonomic nervous system, and also can have referred pain patterns. So again, if you go back to that point on right at the top of your shoulder, if you pinch up in that shoulder, or everybody will probably have a TMJ. So if you kind of push in on your masseter muscle, you know, you'll wonder why a lot of your upper part of your teeth hurt. So you'll get like this radiating pain around your jaw, or you'll get a radiating pain down over your shoulder, because you're getting this autonomic system and these referred pain patterns just from these localized hyper-irritable loci within this taut band of muscle. So trigger points can arise in most muscle fibers, but are frequently seen in muscles that are prone to overuse or mechanical strain, and can have gradual or sudden onset. These untreated or unrecognized trigger points play a big role in creating chronic pain. Trigger points are closely associated with activating muscle nociceptors, and with this persistent stimulation, the patient is at risk of developing central and peripheral centralization. So just remember, we talk about chronic pain a lot, and we talk about wind up an awful lot. So that's where the central nervous system is bombarded with a lot of unnecessary noise. So it upregulates every other noise or painful nociception as being more painful than it actually is. So it just has this whirl and this sort of vortex of pain that's just being upregulated and upregulated and upregulated. So it's really up to us to kind of come in and kind of break the cycle of chronic pain by addressing a lot of these myofascial trigger points and this poor body posture. So chronic body posture arising from chronic pain, degenerative joint changes such as OA, joint injury such as cranial cruciate ligament, and surgery can cause these patients to maintain shortened muscle position for extended periods of time. Positional changes and postural changes can include offloading, lameness, changes in sleep position, and walking. If a dog is uncomfortable, it's not going to sleep properly. It's going to adapt its sleep position around its sleep quality. So all contribute to these chronic muscle shortening and dysfunction in other muscle areas. So as well as allowing the muscles to move easily, fascia also allows fluid, oxygen, and nutrient supply, along with the removal of waste and toxins. So having healthy fascia and treating trigger points and correcting maladaptive behavior of these muscles and maladaptive gait patterns, you're going to get an increase in oxygen and nutrient supply and a better elimination of waste and toxins. So fascia will also produce scar tissue after injury and will also help stabilize during healing. So with muscle dysfunction, fascial injury leads to what is normal and soft and pliable to become stiff and very unyielding. So everybody has worn a really nice kind of loose suit of clothing that allows you to kind of move around. You can bend, you can stretch. Most of us can touch our toes, but I can't. That is your fascia. If you've ever put your fascia in a washing machine and then put it on a high rinse cycle and then a high heat cycle in the tumble dryer, you put that same suit back on and it becomes very tight. And it leads to decreased range of motion. So you can't bend. You start to kind of fidget. You don't want to sit in that suit of tight clothing. So when we get injury and we get this maladaptive posture, we're getting this tightening of this like fiber suit that everybody wears, including our canine and feline patients. So this in turn leads to dysfunction, altered posture, and poor body mechanics. Just remember, we lose that range of motion when that suit is tight and when that fascia kind of becomes very stiff and unyielding. So we have to come in here and we start to do our work and we start to treat the myofascia. We start to go in, we start to stress, chronic postural change, chronic myofascial change, chronic muscle trigger points, and we start to see an improvement in biomechanics. So now let's take a nice big look at a case study, and I think and I hope that this lays it out for you. So this is a lesson in tissue communication breakdown, or when things go badly wrong. I'd like for you to meet Nina. This is my mate, Nina. She presented for a rehab consultation back in 2020. She got a history of mast cell. So there's a lot of things that we couldn't use with her, like class 4 laser. So 2 years prior to that, obviously, she had a caudal right mammary chain, decreased endurance. Her owners said, you know, when she was walking, she would get very out of breath. It would be difficult for her to move. And when she was standing, she wouldn't stand for very long before she'd look for a bed to try and kind of sit. She had chronic right hind limb lameness, and she had a long history of chronic Lyme disease. So some notable clinical findings, including a little bit of bilateral elbow OA, stable but chronic cruciate ligament injury, lordosis, an extremely weak core strength, increased paraspinal tension in her lower lumbar muscles. Her hind limb muscles were atrophied, specifically the glutes, the quads, and the hamstrings. And she had this 2-beat pacing gait. What do we mean by that? So a 2-beat pacing gait is basically when they move left front, left hind in conjunction, and then a right front, right hind. So we get this kind of 2-beat pacing pattern, left side, right side, left side, right side. It's a very inefficient gait. And it really kind of will lead you to sort of understand that if you understand gait patterning, you can kind of target down on what's going wrong with the animal. Here she is. Happy little soul she is, but my goodness, she is a hot mess express. We're going to focus on these little green hearts right here, and give you sort of some idea as to what's going on. Anybody want to have, you know, like a bit of a think? Have a look at this picture. What are you noticing? She's got a big pity smile on her face. What do we notice about her front legs? What about her neck, her shoulders, her bum, her hocks, her tail? What about that undercarriage? Oof, poor little love. So let's take a quick look. So we've got our rear limbs are obviously higher than our front limbs, and her pelvis is tucked. So you'll see there's kind of a little round rumpus going on in the back end. She's got lordosis, so she's kind of flattened out right at her TL junction. We've got some cranial shoulder rotation, so you can see the shoulder joint in relation to the elbow joint and the side of her neck, and you can see that her shoulders are actually pointing a lot more far forward than they should. She's got tarsal extension. Her back legs are dead straight, and she's very wide-based in the back. You see the placement of her 2 back feet. She's obviously wide-based in the front as well, and you can see how much weight she's shifting forward, and she's got low head carriage. So she really is trying to balance her weight between the front end and the back end. She's got low head carriage, and not to mention, you can see underneath the scar. That's a scar from 2 years ago when she had that mammary chain excision. So, you know, we've got a lot of core instability, we've got a lot of myofascial tension, and we've got a lot of compensation. So how do we fix the hot mess express, bless her heart? So all of the points above indicated chronic changes to stance and posture from chronic stifle disease primarily. Weakened core strength stemming from her previous mammary mass excision, and we've got a lot of increased cranial load. So the first steps to managing this case was to ensure adequate pain management, and under veterinary direction, we added amantadine daily, 3 to 4 mg per kg PO SID for a month to address her wind up. And then we did a CC loop or TPEMF to her stifles and her elbows twice a day. Great thing about that is, you know, she's not just having to come into the clinic to be treated, owners helping her at home as well, which is awesome. So the second step was to create a rehabilitation program that addressed the elbow, shoulder, stifle, and hip range of motion, and to improve her core integrity. Most important thing here was small, frequent repetitions of exercise to allow for a gradual increase in endurance, and basically a load and a half of manual therapy. So Nina's biggest problem was the fact that she couldn't walk for very long and she couldn't stand for very long. So making the owner do like 6 sets and 12 reps of a set of exercise isn't going to work. So even if she did assisted standing for 30 seconds, 2 to 3 times a day, I will take that as a win-win. So 3 weeks into treatment, starting to look a little better. So you can see still a little bit of cranial shoulder rotation. She's still holding her shoulders kind of forward. Her elbows are still tucked underneath her. She's still pretty lordotic. Her head carriage is a wee bit better. But look at those tarsi. Her hocks are starting to bend. So, and look at her abdomen. It's starting to tone up a little bit. So we used a very special, and it was a custom designed core band on her at the time. So we took some measurements and fabricated a neoprene and fleece tummy wrap, basically, with some stabilization straps right underneath the umbilicus and some strapping that crisscrossed under, and then the whole thing kind of folded over the top of her and velcroed in place with not too much stress. So I mean, it's a little bit like a Nina girdle. So we were able to activate a lot of her core muscles while she was standing and doing some of these other exercises, gentle land-based closed chain, which means her feet are all on the floor. We're not doing anything like leg lifts. We're not doing anything like sit-to stands. This is pure abdominal core activation and getting her just to use those muscles adequately. So this was 3 weeks into treatment. She's still getting body work. She's still getting her Assisi loop at home. And then we're 6 weeks into treatment. And anybody notice the health of her coat changing? So she's looking a little healthier. Her head's starting to come up. And I promise you, hand on my heart, this is the same dog. Still got a little bit of cranial shoulder rotation, but things are starting to improve. She's looking a little straighter. Her lordosis is starting to resolve. Her hocks are a little straight here because she had a little flare in her stifle OA when we took this picture. But look at her abdominal tuck starting to come up. So we're still working on getting her treatment. We're still doing targeted myofascial release. We're still working on a lot of manual therapy for her along her back, along her neck, through her shoulders and her knees. And she's still wearing her core band when she does her exercises. But now that her core has started to improve, we're actually starting more of the active exercises. So we're starting to do pause up, pause down, a little bit of sidestepping. She's still not quite ready for sit-to-stands, but we're doing elevated sit-to-stands. So she's sitting on a raised platform. So it's not a full squat, it's like a quarter squat as far as we're concerned. And we're doing some leg lifts as well. So things are really starting to improve. Who's this? I swear to God, I swear this is the same dog. So this is Nina 9 weeks after we started doing a rehabilitation program, our T-Penth at home, our Assisi loop at home, and using our core band. Completely different dog. Notice how her coat has changed as well. So not only have we improved her biomechanical function, we've improved her tissue function. So by providing better relief and better movement and better biomechanics, we've improved her tissue perfusion, her lymphatic drainage, and her coat has improved as well. So you can see she's now able to hold her head up nice and high. Her shoulder and elbow position is so much better. Her back is nearly straight. Her bottom isn't sitting up in the air. Her ankles are bending and she's wagging her tail. I tell you, her tail became a demon machine. It really did. So this was 9 weeks after treatment. She started a little bit of aquatic therapy, along with some more active exercises, some cavalettis, some level step overs, some planks. We're doing active planking, obviously still with the core band and core stimulation. She's got better range of motion. Her muscle mass has come up, and everything. She's able to walk. So we've started doing gentle inclines, gentle declines on her walks. She's able to sustain longer walking, so she's actually achieving more lean muscle mass of her own. And at this point, we started to stop the use of the core band because she was able to actually stand without like collapsing, sitting. Her sitting was still a little off center, obviously, because her knees are so thick. So that sort of that osteophytic kind of a proliferation within her knee as a result of her OA just limited her range of motion to the point where she wasn't able to attain a square sit. She put on weight, but it was healthy weight. We were monitoring her chest and waist measurements as we went along. So her weight was attained as a result of lean muscle mass gain and not fat gain. She was eating better. She was pooping better. She was able to hold a posture better when she poops. So the owner was absolutely chuffed to pieces. Shortly after this, she started taking 15 to 20-minute walks, which is something that she hadn't done in over 4 years. So here we go. I promise you this is the same dog. I promise you. We didn't just swap the collars so it was the same color. This is the same dog. But you can notice, look at her coat condition. Look how she's out of breath on the picture on the left and she's just standing. And look how rock solid she is on the right. Head posture, tail posture, rump, lordosis. Look at that tummy tone and look at that abdominal tone that we have right now in the left as opposed to the right. So Nina's continued to do well. She comes in now again for a little tune-up. We do a little bit of shockwave now on her knees, just to help with some of the inflammation in her knees. But she really is doing exceptionally well. These cases take a long time. This is not a quick fix. You know, 9, 10, 12 weeks into treatment, you're still improving and there's still room for improvement with Nina. She's our long-term maintenance care. You know, if she's active, she's more prone to, you know, maybe hurting herself. So she comes in, she'll get her manual therapy, we'll tweak her out, get her all tuned up, and then she's back off out again. So Mum is really, really, really happy. And, you know, we were really, really chuffed. And it's such a big difference and such a visual difference between the two slides. So what did we get? Basically, we got improved pain management. We got way improved core strength. I think, you know, as far as canine Pilates goes, she'll whoop my butt on the core exercises any day of the week. We have near normal weight distribution between her front and rear limbs. We get improved endurance. Her gait pattern changed from a 2-beat to a 4-beat, which is a normal gait pattern when she's walking. Improved joint range of motion in her hips, her stifles, her elbows, and her shoulders. We've got improved head posture and improved limb muscle atrophy, improved atrophy. So what do we glean from this? So the overall importance of injury, chronic disease, and surgery on core strength and posture plays a really vital role when we develop rehab plans in returning a patient to a more natural posture and balance. So understanding how a single unilateral offloading of a limb can have this knock-on effect throughout the whole body over time will allow anybody, and including rehab professionals, to incorporate therapeutic modalities, manual therapy, therapeutic exercise to ensure a successful outcome. I think my favorite part is just remember that everything is connected, so be connected to your patients. There's a really great saying from Walt Disney. So the way to get started is to quit talking and be doing. So I will have you be doing. And I want to thank you for your time. These are some of my patients.
We have an annual Halloween competition every year, and this was some of the ones from last year. These are probably some of the ones that I have most of my postural challenges with, is my little brachiocephalic children. But they're all rock stars in my book, and they're all living happy, healthy lives, thankfully.